Prevention of Iatrogenia in Phlebology. By Dr. Gustavo Leibaschoff. President of the Argentine Association of Aesthetic Medicine, Director of the Aesthetic Medicine Base Course, School of Medicine of the University of Buenos Aires, regular member of the Argentine Society of Phlebology and Lymphology, Secretary of the International Union of Aesthetic Phlebology. Varicose disease of the lower limbs is a very common social disease whose clinical complications cause aesthetic deterioration and negative psychological repercussion in patients. If we also include diseases caused by physicians, iatrogenia, in the course of varicose pathology treatment, it results in patients' frustration and disappointment as promises regarding therapeutic success are not fulfilled due to medical failure. These medical failures can be attributed to patients' lack of information, non-performance of complementary tests, and the want of medical training in the field of phlebology. We consider these are the main causes of phlebologic iatrogenia's high incidence. In order to prevent iatrogenia in phlebology, professionals must be well trained. This accounts for the importance of courses given at universities and schools, such as Argentine Medical Association School of Phlebology or the university course in aesthetic medicine. We will now refer to the prevention of iatrogenic anestheticisms in phlebology. Before speaking about anestheticisms prevention, we must be able to identify them. Due to incorrect medical management, medical lies, and bad sanitary education of the average population, an iatrogenic anestheticism psychologic syndrome has appeared. What can be done to avoid iatrogenic anestheticisms? What are the steps to be followed? First, importance should be given to clinical examination, instrumental tests, cosmetic preparation, dietetic hygienic advice, and elastocompression, which altogether constitute the basis of the treatment. Every patient coming for the first time to the phlebologist's office should be provided with a clear picture of the steps to be followed: correct and detailed clinical examination, echo-Doppler test, cosmetic preparation of injured limbs, dietetic hygienic advice leading to effectual prevention, and the need for elastocompression in the affected limbs. Second, the base treatment itself, which includes physiotherapy through manual lymphatic drainage and sequential presotherapy, and mesotherapy allowing for direct introduction of active drugs into the diseased area. We should also include localized obesity treatment and associated pathology which worsens phlebopathies and shall later be discussed. We will now mention specific treatments for varices: sclerotherapy, mini-incision surgery, hemodynamic surgery, diathermocoagulation, short, long, proximal and distal strippings, and valvuloplasty, surgical procedures to be used as a last resort. Presently, phlebology cannot be practiced without previously performing an echographic Doppler test or a contact thermography. These diagnostic methods are necessary to treat varicose pathologies ranging from effusions, which are the slightest, to degree 3 venous failure, which is one of the most serious ones. If these methods are not used, iatrogenia may occur, as tactic and technical mistakes may be made regarding therapeutic schemes. Cosmetic therapy of a phlebopathic leg is very important for us. When is cosmetic applied in phlebology, and what are the reasons for using it? It is divided in 3 stages. Before starting the treatment, we attend to symptoms: phlebopathic spot prevention, and skin condition improvement. During treatment, we again attend to symptoms, cosmetic action on hematomas, and scar and hyperchromic spots treatment. The third stage begins once the patient is discharged. Our attention is then focused on maintenance, hyperchromic spot treatment, and cosmetic action on cicatrization. When symptoms such as heaviness, cramps, paresthesia, and pain are present, we favor the use of oil-water emulsions whose active principles are ginkgo biloba, Rhuscus aculeatus, Melilotos virginiana, or Aesculus hippocastanum extract. The biocosmetic or epicutaneous action of these pharmacological elements is reliable. We prefer a combination of ginkgo biloba with Rhuscus aculeatus and Melilotos extract due to its synergetic action. As regards phlebopathic hyperchromic spots prevention, same will depend on each patient's phototype. We use creams with hydroquinone 2% or wild rose oil liposome gel. Due to their melanin inhibiting capacity, one of them should be used for 3 weeks before starting the specific treatment for varicose pathology. This applies especially to hydroquinone, as it acts during the transportation and metabolic stages of melanoblasts within the melanocyte and during the transportation of melanoblasts towards the keratinocyte. When we mention skin condition improvement, we refer to its humidification. In those cases, we use an aloe vera or a 12% ammonium lactate emulsion or a liposome gel with superoxide dismutase acting against free radicals with hyaluronic acid sphingosomes because of their humectant capacity. As regards cosmetic treatment for hematomas, we use a heparinoid with hyaluronidase hydrophilic ointment whose results are excellent. Together with ultrasound at 1.5 MHz, mesotherapy with benzopyrone, and manual lymphatic drainage, all of which contribute to a rapid cure. Scars cosmetic treatment is performed with wild rose oil, as it has shown significant results. It is applied once stitches are removed or 7 days after the operation. The wound should be carefully washed and dried, and oil applied twice a day. Scientific studies have proven that after 4 months, a better scar develops, skin is more elastic, and coloring is finer. For cosmetic treatment of phlebopathic hyperchromic spots, we use the following: EDTA chelate or 0.4 gram of a specific iron chelate, deferoxamine, which is used in Europe to treat hemochromatosis. Both EDTA and deferoxamine can be applied cosmetically or mesotherapeutically. The association of any of these products with hydroquinone monomethyl ether at 4% and papain are 0.025 gram alpha-chymotrypsin provides a cosmetic formula for the treatment of phlebopathic hyperchromic spots. However, we all know that prevention of this type of spots is even more important than the treatment itself. If we want to comprehensively treat phlebopathic hyperchromic spots, we should resort to cosmetic using EDTA, deferoxamine, hydroquinone, and papain, and mesotherapy with deferoxamine or ethylene diamine tetracetic. It is also possible to perform a peeling with trichloroacetic at 33% or magnetic or mechanic dermabrasion. When hyperchromic lesions can no longer be improved, tattooing or camouflage can be used to conceal them. Once the treatment is finished, patients are told to continue with cosmetic maintenance, applying an equisetum emulsion at 5 or 15% with a high concentration of salicylic acid, which stimulates connective tissue. Other useful elements are rouge vine extract at 5–10%, aloe vera, which has a humectant and bactericidal effect, hyaluronic acid at 1% used as skin humectant, and melilotous extract as capillary protective agent, lymphokinetic, and macrophage stimulant. During this stage, we must also recommend elastocompression, dietetic, hygienic measures, mainly regarding footwear, overweight control, correct gymnastics, careful sun exposure, and correct mobilization, as well as medical follow-up every 6 months in order to maintain the results obtained through therapy. From a cosmetic standpoint, phlebologists find that phlebopathic pathologies and streaks, which are dermic tissue lesions, depressions of a red-violet color, which then become nacreous white, are constantly associated. For that purpose, we recommend magnetic dermabrasion and the use of liposomes and wild rose oil over the area showing these streaks. A number of cosmetic products has been mentioned, and we would now like to discuss their functions. First, we spoke about wild rose oil, which originated in Chile. It was said that this oil contained a large quantity of oleic, linoleic, linolenic, and non-saturated fatty acids, carotenoids, flavonoids, and vitamin C, which could, however, not account for this product's therapeutic action on scars, spots, and not very deep wrinkles. Many research studies were then carried out in the United States and in Chile. They eventually identified a high concentration of trans-retinoic acid in this oil, resulting in an increased epidermal regeneration speed, normal melanous pigment distribution, and increased fibroblast activity, all of which account for its action. Ruscogenin or Ruscos aculeatus was also mentioned. This phytotherapeutic product has an effect on the vein wall, increasing venous tone because of its alpha-adrenergic effect. It activates microcirculation and improves capillary permeability and edema, acting on venous back pressure. Ginkgo biloba is another very important drug containing flavonoids, terpenes, and proanthocyanidins, which stimulate venous tone and strengthen capillary wall resistance. It acts as anti-edema, lymphokinetic, stimulates macrophages and tissue oxygenation. It acts against free radicals, protects support tissues, and is one of the drugs most frequently used both cosmetically and mesotherapeutically. Acid vitamin A is a very widely used drug in cicatrization processes. It is vitamin A's principal active metabolite developed by Kligman et al. In 1969, when it was first used in topical application. It was seen that at epidermal level, it accelerates epidermal turnover and corneocytes elimination, improving melanosomes distribution and decreasing cellular abnormalities. At dermal level, it increases fibroblastic activity at a 0.05% concentration. It induces collagen neosynthesis, inhibits collagenase, and produces a true angiogenesis after 24 weeks, thus stimulating cicatrization. Melilotus extract must also be mentioned due to its capacity to improve capillary permeability, thus acting on edema or decreasing interstitial edema. Its lymphokinetic effect acts on lymphangioin. It can also stimulate macrophages, favoring the elimination of interstitial macromolecules which increase pressure and cause interstitial edema. Regarding epicutaneous treatment, these are the most commonly used drugs for the cosmetic preparation of all our patients, as their medical and aesthetic results are really significant and they prevent iatrogenic sequelae. As regards hyperchromic spots, we must emphasize they should be prevented rather than eliminated once they have appeared, and this is also applicable to all the above-mentioned iatrogenias. We consider that phlebopathic spot prevention is based on an adequate cosmetic preparation of the limb and not on high concentrations of sclerosing substances. Sclerosis techniques should be strictly executed and sclerosing substances carefully selected. And early thrombectomy in superficial vessels is favored, especially in varicophlebitis. Patients should be reminded to avoid sun exposure after applications, especially if hematomas are present. The affected limb must be adequately compressed, and special attention should be given to post-surgical bandaging in large surgical incisions. Speaking of elastocompression, we should say it might cause iatrogenic consequences such as skin depressions when it is excessively tight. Epidermal vesicles, telangiectasis or reddish effusions might also appear, and even allergic phenomena caused by the elastic included in the bandage. As regards localized adiposis or localized adiposity plus liposclerosis, cellulitis, it is our opinion that when seen together with varicose pathology, they should be eliminated or treated, as these areas alter venous and lymphatic circulation as well as hormone microclimate, resulting in microcirculation disorders. We resort to liposculpture and ultrasonic liposculpture for their elimination. Wrong medical management has raised controversies regarding sclerotherapy, which does not imply merely pricking a vein, and this has led patients to consider it as a negative treatment, which it is actually not. In order to prevent iatrogenias caused by sclerotherapy, physicians should be familiar with sclerosing substances. Each patient's reaction must be observed and an accurate diagnosis must be made with data obtained from clinical examination, echography, and Doppler. Then cosmetic preparation must be performed, and it should always be remembered that this technique is based on skin tension, on making one puncture without traumatizing the vein. Phlebologists should not be persisting in trying to achieve a single intravenous application. Local compression should also be applied, and physicians should wait to verify the action of the injectant product. Thus, iatrogenias resulting from sclerotherapy can be avoided, such as iatrogenic ulcers caused by sclerosing substances, hyperchromic spots, and the explosion of small effusions. These are the most frequent lesions resulting from the incorrect use of sclerotherapy. Iatrogenia prevention in the treatment of varicose effusions should be emphasized. Its importance lies in the high incidence of this anesthetic pathology, its medical underrating, and the large number of iatrogenias occurring during treatment. We believe varicose effusions require an accurate diagnosis, as it is frequently seen they conceal a more significant pathology. such as insufficient perforating veins, which are not diagnosed because of the patient's or the physician's haste, who sometimes does not complete all the diagnostic steps out of fear of losing the patient. Cosmetic preparation has already been discussed, as well as the importance of remembering that an underlying more significant failure exists. Professionals must be familiar with sclerosing substances. Only a few cc are to be injected. A 2 square centimeter area must be cleared, and several intravenous punctures are to be made. We use diathermocoagulation to complement this procedure. For every effusion area, a 3-week interval should elapse between applications. As regards iatrogenic prevention in phlebectomy through mini-incisions, it should be pointed out that this precision-type surgery calls for preoperative kertography, as the use of a scalpel or a 1 millimeter needle requires an exact diagnosis and a perfect cosmetic preparation of the skin. Also, patients must be physically and psychically prepared. Incisions should be made along skin tension lines. They can be either 2 millimeter in length or point incisions. Presently, we use 1 millimeter diameter intramuscular needles. In order to be effective, mini-incisions phlebectomy must be complete, and the edges of the wound should be corrected and a sterile strip effected in order to achieve good aesthetic results. Treated areas should not be exposed to the sun until hematomas disappear. Surgical anestheticisms appear when outdated, not precise, or laborious surgical procedures are employed. Huge, irregular, hypertrophic scars, keloids, and occasionally pigmentations are some of the resulting iatrogenic sequelae. Every leg presents risk relating to skin quality, pigmentation anomalies, trophic disturbances, cicatrization anomalies, and anesthetic stigma from previous treatments that phlebologists should take into consideration in order to achieve optimum results. The importance of good cosmetic preparation of the leg and correct clinical and apparatus-mediated diagnosis should be emphasized to prevent surgical iatrogenia. We must never forget echography, Doppler, cosmetic preparation of affected limb or limbs, preoperative elastocompression, and cartography with echographic marking 24 hours before surgery, which will allow for the preparation of an adequate surgical technique. If keloids are to be prevented, no improvisation can exist regarding phlebological surgery. It is the aim of this presentation to call our colleagues' attention to common iatrogenic mistakes many of us have also made. We must be aware of the fact that a common behavior should be applied, and prevention should become our paradigm, our main objective. Patients should be informed about correct procedures, how treatments are carried out, why cosmetic preparation should be performed, and the importance of diagnostic tests. We should emphasize the incontrovertible value of medical training and information acquired in medical schools that train specialists who are in turn responsible for the prestige of phlebology as part of the wider frame of medicine.